Welcome everyone. I'm Hiba Budaya, the Educational and Patient Program Manager for the ERN-EuroBloodNet, the European Reference Network on Rare Hematological Diseases. It's my great pleasure to welcome you all to today's Thursday webinar. Just a reminder about this webinar series, the aim of this educational activity is to promote interest in innovative topics and highlight the latest advances in rare hematological diseases among healthcare professionals. The webinars mainly focus on rare diseases, complex conditions, highly specialized procedures, and the application of clinical guidelines. So before arriving to today's lecture, I would like to share with you some housekeeping rules. This program is recorded, so if you don't feel comfortable with that, you can turn off your camera, and also your microphones are muted, but at the end of the presentation, you will have the possibility to raise your hand if you want and ask any question. Or you can drop your question in the chat at any time during the presentation, and it will be answered afterwards during the Q&A section. Moreover, this program is accredited, so you can request one continuous medical education point on the European Board of Accreditation in Hematology. Also, if you want to do that, so how to request the credit, you have, of course, to attend the whole webinar, to complete the feedback survey that will be sent to you after the webinar. You need to have an active EBA account, and please use your EBA email in the survey. We also have an AI tool that is integrated into our Zoom. If you wish to use it, you can click on the icon that says "C". Then you select the language the people they are speaking, which is English, and then you choose the language which you wish to have the captions with. So and now it's my great pleasure to welcome our speaker for today, Professor Jens Panse, who will inform us about the latest advances in diagnosing and treating paroxysmal nocturnal hemoglobinuria, offering us a comprehensive guideline to effectively managing this complex and challenging disorder. Professor Panse is a clinician and a researcher at the University Hospital Aachen. His research focuses on clinical research in bone marrow failure syndromes, including PNH, mastocytosis, quality of life, infectious diseases in hematology, oncology, and lung cancer, and also primary CNS lymphoma. He is the head of the Classical Hematology Group and the ECNM Center of Excellence at the University Hospital Aachen. Professor Panse, the floor is yours.
Thank you for the kind introduction. I'm going to share my slides, and I guess we're going to get started. So thanks everyone for attending this webinar. I don't know if you're experienced physicians in terms of PNH, or if you have seen one PNH patient or not any PNH patients so far in your life. So I try to basically cover most of PNH that is these days in discussion. But as has been said from the beginning, please feel free to raise your hands and ask any kind of questions you would like to ask. So the title has been made by EBN, not by myself. Saying Advancing Diagnostics and Therapeutic Strategies in Paroxysmal Nocturnal Hemoglobinuria, Comprehensive Guide to Managing Complex Disorder. So in the title, it says that we have a complex disorder, that there are maybe some challenging diagnostics, and that the management especially is getting very tricky. And this indeed is the case. So when talking about PNH, we not necessarily talk about a complex disorder, we talk about a complement disorder. And what is complex is the complement itself. We all learned the complement strategy during our med school, and we know that the classical pathway and the lectin pathway, as well as the alternative pathway, can all start activating what is called so-called complement cascades, the complement cascade. And this is basically started by acting on these convertases. So convertases basically lead to an activation of some complement factors, and you start with the complement factor C3, which at some point, if there is enough C3 on the surface on the cell, which you can see here on the right side, it starts getting downstream activated. You divide the complement cascade into a terminal cascade, which is below C5, and then a so-called proximal cascade, which is above C5. So everything that happens up here is happening within the fluid phase. And once the activation has taken place, all of a sudden on the cellular level, C3 basically gets activated and all the way downstream to C5, which then turns in the so-called membrane attack complex, or briefly the MAC. And this is tightly regulated normally by complement regulated proteins. And two of these proteins are on the surface of the cells attached to the cell surface, namely CD55, or the decay accelerating factor. You can see here, basically, it accelerates the decay of the C3b, so of this convertase, and the CD59, which is called the membrane inhibitor of reactive lysis, which basically prevents that MAC to be activated, so there is no punching of holes into cells, or in this case, into erythrocytes. So in PNH, those two major complement regulators are lacking, CD55 and CD59. And this is especially worrisome for the erythrocyte, because the erythrocyte is only shielded from the complement activation by these two complement regulating factors in addition to CR1, while white blood cells, for example, in addition have CD46 and other complement regulating proteins. So these two are lacking, and the membrane attack complex is basically activated. And as the alternative pathway is constantly activated, even while I speak, my alternative pathway, and while you're listening, your alternative pathway is constantly activated, this has to be regulated. If it's not regulated, it can basically start destroying red blood cells, and you have your one hallmark of PNH, which is called intravascular hemolysis. So your erythrocytes start to basically get fragmented within the vessels. Now, the reason that these, and this is the complex part of the disease, the reason that these shielding proteins CD55 and CD59 are not expressed on the cell surface lies in what is called the so-called PIK-A gene, which is the phosphatidyl inositol glycan class A gene, which is a part of a protein or several protein machinery that basically delivers these extracellular signals. So this within the ER, the endoplasmatic reticulum, this anchor basically is produced, and you can see inositol and phosphate, which are attached to this N-acetylglucosamine, and this is then transported to the lumen of the ER, where the precursor protein is attached to this complicated structure. Now, the regulatory gene for PIK-A lies on the X chromosome, and we as males only have one X chromosome. So if you have a mutation or a couple of mutations, you don't have an expression of PIK-A, and females only express one X chromosome. And this is why any mutations within these PIK-A genes, and mostly there are several mutations, so mosaic of mutations, lead to the non-expression of this anchor. This can be full-blown, so there is no expression at all, or partially, so that there is some slight expression. However, every single protein attached to this anchor then is not expressed on the cell surface. And this is especially the case in PNH, and you can measure and diagnose this disease by looking at cells in the way that when you do flow cytometry, normally you look at the expression of surface markers. In PNH, you do the opposite. You look at the non-expression of the surface markers. And here, for example, in erythrocytes, if you have a healthy erythrocytes, you see the expression of CD59. These are called type 1 cells. And there's a tiny part of so-called type 3 cells. These are the ones who have no expression of CD59 at all. However, since this is a stem cell disease and you have a clonal evolution of these cells, you can see that the number of GPI deficient cells, for example, in the granulocyte clone, is much higher compared to the red blood cells. And this is because the red blood cells are destroyed And if you would measure reticulocytes and the expression of CD59 on reticulocyte, you would get the same cell clone size of about 55%. So CD24 is another GPI anchored protein, and this one you use for measuring the expression on granulocytes. And there is a fluorocyte chrome, which is called FLAIR, which attaches itself directly to the GPI anchor. And this can also measure the expression basically of the GPI anchor in that FLAIR negative cells basically have no expression. The same could be done on the red blood cells. So this is how you diagnose this disease, basically by finding out that there are cells within the body of the patients that are GPI deficient, and you decide whether or not the clone size is rather high, being 55% in this case, or rather low, let's say 10 or 15%. So when should the testing be done? So when should you perform a flow cytometry? There is that acronym or catchphrase CATCH, which basically points to the fact that PNH is a disease that basically is associated with other diseases, such as aplastic anemia, for example. So if you have a patient with aplastic anemia, looking for GPI deficiency is key. If you have unexplained cytopenia, this might be the reason for that rare disease. If you have especially unexplained thromboembolism in combination with cytopenias, you have a very, very high likelihood of detecting PNH. If you have those rare patients with Coombs negative hemolysis that keeps on going, and if you have a patient with hemoglobinuria that is unexplained. Most of the patients with red urine have erythrocyturia. So if you basically take the urine and let it sit for a day and you come in the next day, you see that the red blood cells are down at the bottom and the urine has cleared. If you have hemoglobinuria, however, the urine will still be red. And these are all patients that you could test for PNH. Although I've said it before, it is a very rare disease with an incidence of about 1 in 1 or 2 million per year. However, PNH is not only a complement disorder, it is also a bone marrow failure disease. And this is one of the reasons why it's basically we talk about within the ERN. So you here can see in this basically well-known figure drawn by Neil Young, that there is a bunch of bone marrow failure diseases. The most likely are aplastic anemia, LGL, telomere biology disorder, inherited bone marrow disorders. But there's also PNH as part of the bone marrow diseases, bone marrow failure diseases. All these diseases can basically secondarily transform into MDS, high-risk MDS, or acute myeloid leukemia. And the easiest way to remember PNH is that it is a yin and yang besides between the aplastic anemia and the PNH, which is basically depicted on the next page. So if you have a pressure on your marrow, like, for example, by autoreactive T cells in the case of aplastic anemia, this pressure will lead your stem cells within the marrow acquire any form of mutation that basically might lead to a growth advantage. So this could be a bad mutation like ASXL1 or DNMT3A, or this could be a mutation like PIK-A. And if this mutation would be picked up, then these cells all of a sudden might have a growth advantage, and your erythropoiesis and hematopoiesis all of a sudden might rely on cells that are PIK-A mutated, AI GPI deficient, and they have a growth disadvantage in terms of the red blood cells because they get lysed by complement. However, in the fate of having an immunoselective pressure, they might have a growth advantage. So this is why, and I go back again, why aplastic anemia and PNH are always interrelated. And you rarely see a patient with PNH who has not some form of aplastic anemia, at least in the background, be it maybe just thrombocytopenia or even overt cytopenia. There's a very nice review about the relation between aplastic anemia and PNH done by Lucio Luzzatto and Nakao. And this shows you that if you have an aplastic anemia, your blood cells are rather low and your blood counts within your peripheral blood. And the same holds true if you have PNH. If you just look at the GPI positive cells, which would be the non-PNH cells. So if these cells basically have are the majority within your marrow, then you might have aplastic anemia. If it turns out that some of the cells also become GPI deficient, then small clones of PNH GPI deficient cells might be detected within the marrow of aplastic cells. However, if all of a sudden these cells rise and give rise to the new hematopoietic system, then you have overt hematological PNH. This is also shown on this right side in this cartoon, where you can see if you have cytopenia and bone marrow failure with a small clone size of PNH cells, you treat these patients with immunosuppressive therapy or bone marrow stem cell transplantation. Whereas on the other side, if you have dysregulated complement and a hemolytic PNH patient, characterized by hemolysis, anemia, a high risk of thrombosis, and all these symptoms, you treat those patients with complement inhibition. So if you then go to the management of patients, the first thing you have to think about is this a patient with aplastic anemia and a small PNH clone, or is this a patient with a pure hemolytic PNH? And there's no clear definition of what, hemolysis and all that defines, but we normally talk about hemolytic PNH if the cell clone, and it says here the white blood cell clone, as explained before, is equal or more than 10%, and if the LDH is upper than 1 times to the 5th of the upper normal limit. In this case, if the patient is symptomatic with hemolytic PNH, you treat them nowadays with complement inhibition. In those rare cases where the patient is asymptomatic or is non-hemolytic because the clone size is rather low, or it is not a complete deficiency of GPI expression, but just a slight deficiency. So you have those type 2 cells, which are in between the type 1 and type 3 cells. You can consider supportive therapy, anticoagulation, and just watching the patients and regularly checking for an increase or decrease of the PNH cell clone. So the advent of complement inhibition with the introduction of eculizumab at the beginning of the 2000s has really changed the disease. So you can stop the complement mediated membrane attack complex at the C5 level if you basically give the patient an antibody against C5, and this used to be eculizumab. Nowadays, we use ravulizumab most of the cases. There's also crovalimab, which can be given subcutaneously. Eculizumab and ravulizumab has to be given IV, ecu every 2 weeks, and ravu every 8 weeks. And by this, basically, you change the course of the disease in that hemoglobin basically increases, LDH decreases because hemolysis is stopped. Thromboembolic event, which have been before the major cause for morbidity and mortality in this patient, basically decreases. Secondary sequelae like pulmonary hypertension, kidney failure, fatigue, they all decrease. Quality of life increases. And you can see here on the right side in a collection of patients from Leeds, who have the largest basically amount of patients collected. These patients have all been treated with eculizumab and ravulizumab, and if you compare the overall survival to age-adjusted normal or healthy population, you can see that basically these patients have a good chance of living as long as their normal counterparts, although there are some people in the end who might die earlier, and the major reason is either the transformation to aplastic anemia or risk for infection, but none of those cases basically these days, if there are under C5 inhibition, die because of thromboembolic events, except for extremely rare cases. So the introduction of this terminal inhibition basically changed completely the course of the disease. PNH is the only disease in hematology where the successful treatment increases the disease amount, because all of a sudden your red blood cells, which would normally die because of intravascular hemolysis, are shielded from the complement disease, and you have a sick red blood cell that is basically shielded by your therapeutic intervention. So the amount of disease basically increases instead of decreasing. There are other things that happen if you introduce complement inhibition at this terminal level, and we're going to come to this later on. So this is what basically this treatment algorithm really looks like. I only shown you the small part of hemolytic and non-hemolytic, asymptomatic and symptomatic, and put in here complement inhibition. But there's way more things we have to consider these days, as there are more therapeutic options, not in every part of the world, but in a lot of parts of the world, and hopefully the more we talk about it, and the more access to treatments are to more and more parts of the world. So if you talk about PNH these days, you have to talk about several things we haven't thought, from the get-going when we introduced C5. One is what we call extravascular hemolysis, and I'm going to talk about this in a minute. We talk about terminal complement inhibition. I showed you this by the C5 inhibition and what we call proximal complement inhibition. There's a phenomenon that is called breakthrough hemolysis we have to take into account. There are patients with small clone sizes who get complement inhibition and immunosuppressive treatment. There's the rare case of pregnancy, but every pregnancy within PNH is a high-risk pregnancy. There's the question of anticoagulation and quality of life. And these are the things I want to talk about in the remaining time. So in 2007, we started, at least in Europe, with eculizumab as the first complement inhibition. Eculizumab had to be given every 2 weeks, and this has been further advanced by the introduction of ravulizumab, which has to be given every 8 weeks, which is a major step forward for patients, but also for physicians, because patients now basically can do whatever they want in between those 8-week intervals. They can go on vacations, they can, go to rehab centers, whatever. And it was really, really hard to do all this once they had to come to see a physician every 2 weeks. The route of administration is always IV. And in Germany, we have to have the patient come to the doctor's office in order to get their complement inhibition. In other countries, patients are giving these medications at home. For example, in England, in France, they can give it themselves at home. So it really, really depends in which country you live, how you use these different drugs. There are new drugs, which I basically highlighted by this yellow sticker, which are all so-called proximal inhibitors, which I'm going to talk about later. And then I said before, in 2024, crovalimab has been introduced and has the great benefit that it can be given and administered by the patient themselves as a subcutaneous injection every 4 weeks, which makes it a lot easier to use than these ones. However, there are patients who rather like to come to see you every 8 weeks and see their physicians every 2 weeks. And so there's all these ideas you have to discuss with the patients nowadays, which is the drug that suits the patient best if the drug is available in your country. So when we started blocking C5 and saw the survival curves and the decrease in thromboembolic events and all these other things that became better, we never thought about what would happen if we block C5. What happens is the proximal cascade is still active. And since those erythrocytes are shielded from the complement attack, this active complement system basically is still happening on the surface of the red blood cells. And you have fragments of the C3 basically attached to your red blood cells. And these fragments are very, very attractive to your macrophages within your liver and in your spleen. And all of a sudden, you turn an intravascular hemolysis, which is a Coombs negative or DAT negative disease, into a Coombs positive disease, because you shield those cells and you have what we call extravascular hemolysis within the spleen and the liver. This is very important. The major part of this happens in the liver, so it doesn't make sense to take out the spleen. And if you have a patient on a C5 inhibitor and he's doing well or she's doing well, and all of a sudden hemoglobin level decreases, reticulocytes increases, the LDH might slightly increase, but you have signs of bilirubinemia like you have in a classical extravascular hemolytic event, or increase in fatigue, or measurements of this C3 fragments on the cell surface of these cells, or a positive Coombs test. This is when you have to realize, oh, this patient is suffering from extravascular hemolysis, basically introduced by your treatment with the C5 inhibitor. How often do you see this? There's no clear definition of extravascular hemolysis, but I'd see every fifth up to every third patients experience clinically relevant extravascular hemolysis. And this has been a huge problem because we have had no chance to basically deal with it. Up until we thought, hey, maybe it might make sense to basically block the complement way up earlier. We were very reluctant to do that because we thought that if you block the complement up here, patients might suffer from very severe infections because, like children who are born without C3, they suffer from severe infections. Children who are born without factor B or factor D, all these deficiencies suffer from severe infections. But it turns out that if you take an adult in whom the immune system has already been developed, you can block C3 or factor B or factor D without having an increase in severe infections. And so there's new drugs. The first one of those have been pegcetacoplan. This one blocks the C3 here at the center. It has to be given subcutaneously twice weekly. And if you take a patient who has been treated with eculizumab or ravulizumab, and you introduce pegcetacoplan, hemoglobin level within no time increases up to 12 grams per deciliter. In this study, half of the patients had to go back on their C5 inhibitor. So unfortunately, they went down with their hemoglobin level. And after a couple of weeks, they were given the C3 inhibitor again. And you can see here over time that those patients achieve hemoglobin levels which are close to the lower limit of normal in females. So 12 gram per deciliter, something we would have never anticipated before in this patient population. With the advent of this first proximal complement inhibitor, other companies developed new complement inhibitors, and the second one has been iptacopan. This is a drug who can be given orally, which is also a major step forward. Twice daily, it has to be taken. And exactly the same basically results happen in the study that has been done here. This is the so-called APPLY study, in which patients with extravascular hemolysis with low hemoglobin levels were basically randomized in an 8-to-5 fashion to either receive iptacopan, and you can see the increase of hemoglobin, or had to stay on the C5 inhibitor, and later on was switched to the proximal inhibitor. And you can see again this major cutoff of 12 grams per deciliter, which basically is the same number as up here. And you can see the increases in hemoglobin levels for these kinds of patients who had been on their C5 for quite some time without an increase in hemoglobin levels. Now, there are patients and physicians who were afraid that if you would put a patient on a proximal inhibitor, this might change the disease course and it might not be the best. So they thought, what if we combine proximal inhibition together with terminal inhibition? In other words, a belt and trousers approach. And this has also been tried with what is called danicopan. This has to be given thrice daily. It's also a tablet. Why thrice daily? Because pro-factor D is constantly developed into factor D, into mature factor D. And even if you block mature factor D, there's constant new factor D which is produced. This is why you have to take 3 pills daily. And if you add this to ravulizumab or eculizumab, you basically again have the same effect as above here. Now you would say, okay, here is your 12 gram per deciliter level, while these patients not achieve those 12 gram per deciliters. If you look real closely at what point the patient started, you can see here it's 8.7 grams per deciliter. You can see it's 8.9 grams per deciliter in this trial. And you can see the level in this trial is rather 7 point something deciliter. So if you add the 1 gram per deciliter and you move the whole curves up here, you basically have the same effect. However, as you can see with the standard deviation, it seems that the factor D inhibition is a bit tougher than the factor B inhibition or the complement factor C inhibition. However, nonetheless, it works quite nicely, and there are patients who feel really, really good on this combined treatment. So you have 3 different options now to basically block proximal complement inhibition by either blocking complement factor C3, by complement factor B or complement factor D, and you can choose, if those drugs are available in your country, which one you're going to take. If you look at the clinical response in terms of fatigue, you can see basically the same curves again. Again, this is factors. It's pegcetacoplan, C3 inhibition, factor B inhibition, iptacopan, and danicopan factor D. And you can here have the same curves if you measure fatigue levels. The higher the levels, the less the fatigue. 43 is the median population norm. So you can see basically the same thing, combination of C3 with C5, and your fatigue goes away, comes back and goes away again, or not goes away, but decreases. Same thing with iptacopan, and the same thing with danicopan. So these drugs not only basically help to increase hemoglobin levels these days, these drugs also help to make the patients feel better because their hemoglobin level increases so much that it basically reaches levels which are close to what is seen in patients or people who are not affected by PNH. Of course, with a very success story like this, if you switch patients, you can reach normal hemoglobin levels. One thinks about the fact, what if I put a patient on a proximal inhibition from the get-go, from the beginning? And there are studies that have been done in these patients as well. This one has been a randomized in which pegcetacoplan has been randomized to best supportive care. This, of course, could only be done in a country where no complement inhibition had been available. And you can see here that within no time, same thing happens with these patients. They reach hemoglobin levels which basically are unprecedented in patients who are naive and are treated with complement inhibitions. And the same thing is true for iptacopan in this case. And you can see that over time, it takes a little bit longer compared to the switch patients. The reason is that these patients are all iron deficient. And within the studies, iron supplementation was not allowed from the beginning, only later on. And so once the iron stores are repleted, those patients basically have classic normal hemoglobin levels. So proximal inhibition can be used as second line or switch treatment, or even in first line if approved in your country. So to sum it up, proximal complement inhibition can be used as a switch from terminal to proximal. You see an increase in hemoglobin. You see also an increase in your clone size. I didn't talk about this, but the better you shield your PNH clone, the higher the clone size gets. You see a decrease in reticulocyte count, so you see a decrease in fatigue, and you see a decrease in LDH, which is not that high from the beginning anyways. You need a different infectious disease risk mitigation strategy. So patients with C5 inhibition have to be vaccinated against meningococcal disease. If you put a patient on a proximal, you also have to vaccinate them against pneumococcus and Haemophilus influenza. And what we do is we give them a pill in the pocket or an antibiotic so that they are safe whenever they have a fever. They know they can take their antibiotic and see their physician. You can see an increase in hemoglobin even if you put a patient or switch a patient with an extravascular hemolysis who has a hemoglobin level which is not that low. For example, patients with a hemoglobin of 12, you would say, why would they need to be switched to a proximal complement inhibitor? Well, there are patients who basically maintain their hemoglobin level of 12 just because their marrow is so active that their reticulocyte count is around 400 or 500. If you switch these patients, their hemoglobin level goes up to 15. And so even patients with extravascular hemolysis that doesn't enter basically or lead to a severe decrease in hemoglobin levels can or should or would be switched to proximal inhibition. And I've shown you that it also works in naive patients. So basically what you can do now, and what this cartoon depicts, is if you have a symptomatic PNH patient, if you look at the label of the different drugs, you can start first-line complement inhibition terminal with either ECU, RABU, or CROVA, or you can start first-line complement inhibition with IPTA or pegcetacoplan. If those patients then lose their response to the terminal inhibition, those patients can then be put on pegcetacoplan, iptacopan, or danicopan can be added as seen in the trial I showed you before. If the adequate hemoglobin level shows an adequate rise in hemoglobin and no rise in reticulocytes and no signs of EVH or extravascular hemolysis, you can, of course, leave them on the C5 inhibition. And the big question nowadays is, should we put all patients on proximal if we could, or should we start with terminal and put only those on proximals who are not doing well? And this is a matter of debate that is still ongoing. So we were all hoping with the availability of new drugs that there would be a decrease in costs because these drugs are all insanely expensive. And together with the ERN, we did a study in which we asked about reimbursement and availability of all these drugs who are basically licensed by the European pharmaceutical agencies. And you can see, unfortunately, this is an analysis about the costs of these drugs. In intravascular eculizumab costs about $60,000 for the first month and then $50,000 every month after. RWTH has about the same price. Pegcetacoplan is not that much cheaper. And even those oral drugs basically have monthly costs of $55,000. Imagine a yearly therapy, which is $500,000 in tablets. Unfortunately, even the competition of these drugs so far has not led to the fact that one of them became less expensive, and there are still differences. I've asked around to colleagues, Austria, Denmark, France, Germany, Italy, and Switzerland, and to be honest, actually, the only country of all these here in which all of these drugs are shown you are reimbursed at the moment is Germany. There's another country, um, Great Britain, in which all these drugs are reimbursed, but not even in rich countries like Switzerland, Italy, or France is availability given for all these drugs I've just shown you. So from the beginning, whenever we have patients on complement inhibition, we had a phenomenon that is called breakthrough hemolysis. What is breakthrough hemolysis? Breakthrough hemolysis is a patient who's doing well on complement inhibition, and all of a sudden, his or her hemolysis comes back because the drug is not effective anymore, or the complement is activated in such a way that the drug basically cannot hold the complement in its steady state. And this is shown here on the right side. So you have your complement cascade, again, C3. Down here, you C5, you give a C5 inhibitor, and the erythrocytes are shielded. You have your normal cells, you have your PNH red cells, you have your extravascular hemolysis cells, and you can have chronic extravascular hemolysis. So if your drug doesn't work anymore, let's say there's two C5 which can slip through, then all of a sudden you have some of those PNH red cells which are lysed in addition to those ones are phagocytosed by extravascular hemolysis. And this is what we call breakthrough hemolysis. There is a not so strong definition of a hemolysis, but the accepted definition is that there is clinical breakthrough with a drop of more than 2 grams per deciliter with signs and symptoms, or less than 2 grams per deciliter without signs of symptoms, and a respective or corresponding increase of LDH levels. So whenever we had breakthrough hemolysis with C5 inhibition, we were not that excited because most of those patients didn't have a very severe drop in their hemoglobin levels. The reasons for those drugs not to basically be effective anymore can be twofold. The first one is what we call the pharmacokinetic breakthrough. And we saw these breakthroughs under eculizumab because we knew the dosing of eculizumab was a little bit too low. And so there were lots of patients whom we gave their dose. And when they came back after 14 days, they usually started hemolyzing again. So we either increased the dose or we decreased the interval between the two eculizumab doses. You can see here pharmacokinetic breakthrough, eculizumab plasma level inadequate. However, there are effects we call pharmacodynamic breakthrough, and these are basically accelerations of the complement system. So whenever the complement system is activated by pregnancy, vaccination, infection, surgery, whatever, the level of C5 inhibition might not be enough and you might have a breakthrough. There's nothing much you can do except for treating the event, for example, treating the infection, or see that the vaccination is done at the beginning of your C5 inhibition, and basically in order to circumvent these issues. The situation completely changes with the introduction of the proximal inhibition, because all of a sudden, when we had a complete blockage of the complement, I said that before, the number of GPI deficient red blood cells increased even furthermore. So you see patients who have a 95, 97, or 99% GPI deficient cell clone under proximal inhibition. And in this case, if you have a breakthrough, let's say at the level of C3 or factor B or factor D, then this multiplies because this C3 will activate more than one C5. And now you have a completely unshielded GPI deficient cell clone, which then basically it gets hemolyzed quite strongly, and you have acute breakthrough hemolysis with a far larger number of red blood cells who will be destroyed. And this is why we met and made a consensus on the severity of breakthrough hemolysis, because you can see patients with even a drop of equal or more than 4 grams per deciliter, which is then called severe breakthrough if you under a proximal complement inhibitor. This has been unprecedented and has not been seen in cases with terminal. Rare cases it has been seen, but there is clearly a qualitative difference in a breakthrough hemolysis of a proximal compared to a terminal complement inhibitor. This is why there is guidelines now, and this one is for pegcetacoplan, in that if you have a breakthrough hemolysis, you look for so-called complement amplifying situations or events. And if you can treat them, treat them. But if you cannot treat them and the patient might need transfusion, transfuse them because you can dilute the GPI deficient cell population, or you have to give additional pegcetacoplan in that normally you give it twice per week, that you give it 3 times in a row or thrice weekly. There's questions about those modifications and treatment of this breakthrough hemolysis for all the other complement inhibitors at the moment. And we've also seen something that we never experienced before. If you have a patient who has been on a proximal complement inhibitor and wants to go back on a terminal, and this has been a case in which a study drug was not available at a certain point in time, that all of a sudden you can even have extravascular hemolysis as a reason for breakthrough. So there's all these new kinds of breakthrough hemolytic events which you and your patients have to be educated about. This is from that hematology paper in which basically you can see breakthrough hemolysis and the different drugs and what to do about those different drugs. The problem is, since all these drugs are so expensive, that, for example, if you have a breakthrough on pegcetacoplan or under iptacopan, and you want to stop that breakthrough by adding, for example, terminal inhibitor, no one knows how to basically get eculizumab or ravulizumab because one has to pay for it. In Great Britain, they have a system in which the basically clinics in Leeds and London can add eculizumab to iptacopan or pegcetacoplan or whatever. But in every other country, it's rather tough to basically come up with terminal inhibition. And this is why we need guidelines how to treat these patients, guidelines from the companies, and also guideline from the PNH community. And these guidelines are, as we speak, basically developed. What you need to do is you prevent complement inhibition. So you have to educate your patient, and especially if you have a patient who used to be on a terminal inhibition and you now put on a proximal inhibition, a patient who has been used to breakthrough hemolysis and basically disregards it as a subclinical event, you have to make sure that these patients are aware that if they are on a iptacopan, pegcetacoplan, or even danicopan, when you have the combined, that if they experience breakthrough, that this can be way more serious than they used to basically experience it under terminal inhibition. Now, what with those patients in which you have a very, very small cell clone, physicians always ask me, should I put this patient on complement inhibition because we detected a cell clone of 6% or 5% and the patient is not feeling well? It's a really, really hard decision. And there's also a consensus paper in which experts met, which has been submitted. For example, if you have a clone size of less than 10% without any thromboembolic event or clear hemolytic event, there is no need. It is even considered to be inappropriate to put those patients on complement inhibition. If you have a thromboembolic event no hemolysis, the likelihood that this thromboembolic event is caused by this very, very clone size is rather small. But in case of it is for example, thromboembolic event within the splanchnic veins or whatever, then of course you would put these patients on complement inhibition. When you have clone sizes between 10 and 25%, again, thrombosis is always a trigger to put those patients on complement inhibition. If you have no thrombosis, any rather small clone size, if your hemoglobin is okay, no signs of hemolysis, you don't have to put them on complement inhibition. Again, there is a definitive worldwide guideline lacking. The International PNH group is about to basically publish these guidelines, and hopefully they will be done by the end of the year. Now, what if you have a patient who has aplastic anemia and PNH and you want a bone marrow transplant this patient? Can you give complement inhibition up until the transplant, or even furthermore after the transplant, until this PNH clone has been gone away? Of course, you can do this. There are several papers with eculizumab, with ravulizumab. There's been experience with all the other complement inhibitions. So if you have a patient and you want to give him ATG and cyclosporin, for example, and he's still hemolyzing, you can basically combine these two events. Same holds true if you have a patient who has been on ATG and is slowly recovering with his cells with an aplastic anemia, and all of a sudden is the experience hemolytic events. You can put these patients on complement inhibition. The last one is pregnancy. Pregnancy, as I said before, is always a high risk in patients with PNH because of that high risk for thromboembolic events, especially the second and third semester and the time around birth are very, very high risk things. And the best experience so far has been with patients on eculizumab, higher than usual doses. They need heparin, they need aspirin, and all kinds of other things, and have to be watched really closely. However, there's more and more patients with ravulizumab, and this has been a paper that has just been published in Blood Advances, patients who've been compiled together by Britta Höchstmann and colleagues. And you can see here ravulizumab-treated pregnancies with 100% live births in all these pregnancies, some complications, but of course, ravulizumab is another drug that can most likely be given safely. Finally, if you have a patient with PNH and all these different options these days, this is a very rare disease, and you have to make sure that you give the best drug and the best treatment to the patient, and quality of life for these patients is very important. And if you measure quality of life, don't hesitate to use the questionnaire that has been developed for these patients. It's available in all different languages. If you have never heard of it or you want to have it in your language, just send me an email and I can send it to you. Don't use just the FACIT-Fatigue or the ERTC, because those are cancer-related quality of life questionnaires that are not appropriate to be used in PNH patients. And with this, I guess I can conclude that we talked about the complement and bone marrow failure as the reasons for being having PNH, that we talked about proximal and terminal complement inhibition. There's new therapies. This is a new disease under new therapies. There's new complications. There's difference in availability of drug. Reimbursement is a problem. Treatment structures are different. And if you want to learn more about PNH and you want to come to Naples, this may feel free to be welcome at the third IPIC conference. And with this, I thank you very much for your time. I thank ERN for organizing this event, and I'm happy to take any questions.
Thank you so much, Professor Panse, for this very comprehensive presentation. We already have some questions in the chat. So the first question says, terminal equal proximal or distal to what?
Terminal equal proximal or distal. So some people call terminal also distal complement inhibition, and the differences are in distal and terminal compared to proximal. And it's not equal. I've shown the differences in the complement inhibition. I showed the differences in effects, and the experience with terminal, or what we call distal complement inhibition, is so much. There's so much more experience compared to the proximal that a lot of physicians who basically have availability of proximal and terminal or distal complement inhibition start putting patients on a distal terminal complement inhibitor and then switch. But you can do it otherwise if patients are very compliant, for example, and they are aware of the disease and they want to have an oral drug, you can do if you want to and if you have the availability of the drug. I hope this answers the question.
Thank you for the answer. The second question is, which CI, so complement inhibition, would you recommend to patients who want to become pregnant?
So like I said before, so it used to be that eculizumab was the drug of choice because we know how to deal with pregnant patients under eculizumab, but it seems that ravulizumab is at least as effective. There might not be the need for dose increase, although a lot of those patients who have been compiled by Britta Högsman had increasing in doses or shortening of the interval. So if you want to be sure and you have no experience, I'd still go for eculizumab as the safest bet. But if a patient is on ravulizumab and does not want to go back to 2-week infusions, I guess to have her on ravulizumab is as equally as effective. There have been two reports of pregnancies with pegcetacoplan, rather difficult, and there are pregnancies within the iptacopan trial, but there's only, I think, one baby that has been delivered. So I guess there's more and more experience that will come over the years, but at the moment, echo is the safest bet.
Thank you for the answer. The next question, do you routinely stop anticoagulation on patient under complement inhibition?
So this is a very good question. If you have a patient who has never had a thromboembolic event and you put him on a complement inhibition and he used to be on anticoagulation because you had no reason to initiate complement inhibition, these patients I would all stop routinely once they are on complement inhibition. And you can do this, after 2 weeks, 6 weeks, 8 weeks, or 3 months, whatever you want to do. The tricky patients are the ones who have a thromboembolic event and under complement inhibition. And if these patients have had a distal vein thrombosis in their leg, I would still stop complement inhibition. But if the patient have had a splanchnic vein thrombosis or Budd-Chiari disease or whatever, I guess most of us would not stop anticoagulation, but continue anticoagulation.
Okay. The other question is
Pegcetacoplan during
pegcetacoplan.
pregnancy. Yeah, I can see it. I can see. Like I said, there have been reports about 2 patients with pegcetacoplan pregnancies. Both have been reported. You can check them out. You can find them in PubMed. Pregnancies have not been easy. The one in Canada is an easier one, but she also needed eculizumab around the time of birth. So if the patient is on pegcetacoplan, I would really, really closely monitor the patient and make sure that, in the case of anything might happen, you have a C5 inhibitor available.
Mm-hmm. And the next question, vaccinations need booster?
Yeah, once or need booster. Also an excellent question. So in Great Britain, they have the luxury of measuring levels of vaccination. So you can vaccinate against meningococcal disease and you can use the titers. And when they check the titers, they decide whether or not the patients should be revaccinated. If you don't have that opportunity, and we don't have that opportunity in Germany, we do boosters every 5 years.
Okay, the other question, thanks for a great talk. How do you manage the transition from one long half-life complement inhibitor to another with regard to immune complex formation, for example, when switching from
Crovalimab to Ultomiris. Oh, this is also an excellent question. Okay, I haven't talked about this, but so you have your C5 inhibitors and you have your complement factor 5, and crovalimab binds on a different site that eculizumab and ravulizumab. So there's alpha and there's beta, and one of them binds on alpha and the other one binds on beta. So if you have a patient on ravulizumab and you add crovalimab, you can have that unlucky experience that you basically build complexes. So you have your C5, you have your your ravulizumab, and you have your crovalimab. You have another C5, ravulizumab, crova, another C5. So you have these large complexes which can form, and these basically can lead to autoimmune diseases, inflammation. So it is a very, very unpleasant experience for patients and physicians. So whenever I would switch a patient from ravulizumab to crovalimab, I would first put them back on ECU because you don't have that experience on ECU because it's not a long half-life, and then add the crovalimab. It's a bit cumbersome for the patient and the physician, but we had some serious side effects from switching patients from Ravu to Krova, so I would not recommend doing this.
Thank you for the answer. The last question says microRNA that blocks C3 hepatic production shows good results in IgA
Yeah,
nephropathy. Can it be used baseline for complement-related diseases?
yeah. So nephropathy is different in terms of the localized C3 accumulation is what is key, but um, MRI approaches are also used, or MRI RNA approaches are also used in complement-mediated disease such as PNH. There's one company, for example, that basically adds a C5 mRNA together with a C5 inhibitor. There have been Chinese companies who presented data at last year's ASH also about mRNA inhibitors. So yeah, this might be an attractive approach. Another one would be, for example, CRISPR-Cas gene editing of the PIK-A gene. And so, yeah, these things might come, but at this moment of time, complement inhibition by the drugs I've been mentioning are still the standard of care.
Thank you. One more question. Fluid phase and tissue phases complement activity. What is the main triggers and differences?
So the whole complement activity basically happens within the fluid phase most of the time. Even the alternative pathway is basically is constantly activated within the fluid phases. The 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 differences in the tissue phases is in the setting of PNH, that basically everything that happens after C3 is happening on the cell surface, and this is happening on the erythrocytes. This completely differs, for example, from C3 disease, nephropathy, or other diseases in which you have a localized activity of your complement inhibition. So the lectin pathway, the classical pathway, and they can be activated by apoptosis, cell death, by bacteria or any other kind of disease. And this mostly happens within our serum. And once we go to the C3, then everything happens on the cellular level. And this is the reason why, for example, if you have your C3 on your erythrocytes, or a lot of C5 on your erythrocytes, and a lot of eculizumab on your erythrocyte, or a lot of ravulizumab on your erythrocyte, you can bypass activation of the complement system from proximal to terminal. And this is one of the reasons why, for example, if you have a breakthrough under ravulizumab, it doesn't make sense to add more ravulizumab, because the ravulizumab has altered on the surface of the erythrocyte the complement fragments already, and so more ravulizumab would not help. So there are a lot of subtle differences, and we haven't completely understood the way the complement works and functions. There is stories about mitochondrial complement these days and all these other issues. So there are still a lot of things to do and a lot of ways to go.
Thank you so much, Professor Panse. We don't have any more questions. I would like to thank you for the brilliant presentation and for the discussions. Thank our audience, and I would just like to remind them in the end that we're going to have another Thursday webinar. I'm sharing my screen. Here is it. It's on von Willebrand factor and von Willebrand disease in aging, mechanisms, up,
Wrong
evolving
speaker.
phenotypes, and clinical implications. It will be by the speaker Omid Zainzadeh on the 12th of March. So if you would like to join us, you can scan the code and register.
Thank you very much. Have a
Thank you
great
so
evening.
much. Have a great
Bye-bye.
evening, everyone. Bye.